hopefully our screen won't fall down in the middle of the talk. It is taped, so I apologize. So this will be live streamed, where people can go back and watch it. You know, not too many people watch live, but then we'll also have it recorded. If you don't mind, we'll have it recorded. So, I'm sorry.
I'll clean it up.
Anything you do will be much appreciated. Sorry about this, just take a second. Okay, so, ladies and gentlemen, thank you so much for joining us tonight. We have an amazing speaker here, Dr. Angela Lanfranchi. I'll let her say a little bit more about herself if she would like to, but over 30 years, I think, as a breast surgeon associated with the Robert Wood Johnson Medical Facilities in New Jersey, where Dr. Angela's from. Amazing, amazing research. She's currently the president of the Breast Cancer Prevention Institute. Dr. Lanfranchi has been one of the pioneers in the promotion of the ABC link, the abortion breast cancer link. And so her current research has led her all the way through the harms of hormonal birth control, even to violent death of women associated with long-term hormonal contraceptive use. So we look forward to this hearing about this recently published paper by Dr. Angela, and feel free to mention anything else that maybe I have not mentioned.
No, that's it. Thank you. So, there were 2 large cohort studies, groups of people that were followed many, many years. And one of their findings were that hormonal contraception was linked to violent death. So that always intrigued me. And violent death, in medical terms, there's something called the ICD-9 or 10. They've got different editions, codes. So everybody who goes into a hospital has to have a diagnosis code. And they also use them for causes of death. So violent death is considered homicide, suicide, or accident. And sometimes, you know, you can think that somebody had a car accident, but it was a single car accident and there was no bad weather, and that's how some people choose to kill themselves. Overdoses could be either or, and death by cop. You know, you do something, you know you're going to get shot. So in the United States, 1/3 of the female homicides are by an intimate partner. 1/3. And 30% of all emergency room visits for trauma by women is trauma inflicted by their intimate partner. And homicide is the leading cause of death in pregnant women. So if you look at what the CDC, Centers for Disease Control, said in 2017, for 1 to 19-year-olds, 10% were suicides, 7% were homicides, and 20 to 44-year-old, suicide was 7%, and homicide almost 4%. So you can see it's not a little problem. So, as I said, I managed to get this paper, even though it kind of had an inflammatory title, Hormonal Contraception and Violent Death, the Physiological and Psychological Links. I managed to get it published this past July. It took 6 reviewers to get through peer review over a 5-month period, so there are 4 revisions of this to make it acceptable to everybody. So this all started when I was researching for a talk on the 50th anniversary of the pill. Time magazine had a cover story in 2010 celebrating the 50th anniversary of the pill. And what they said was so strong, so powerful, so misunderstood. You know, they couldn't figure out why more people weren't taking it. So what they said was when they did this large cohort study in March of 2010, that was released in the British Medical Journal, it said women who take the pill are less likely to die prematurely from any cause. So not only was the pill safe, it seemed to be better for you. But that was really fake news. They were talking about the Hannaford study. If you just read the first page of that paper that was published, in the abstract, it said, "We are unable to explain the increased risk of violent and accidental deaths in our study among ever users of oral contraception. The persistence of this effect is noteworthy," meaning that the Royal College of General Practitioners in England had a cohort study of everybody in the UK that was taking the pill. And they were just seeing what happened to them. They were following them along. In 1999, they found that it increased the risk of violent death. And then Hannaford is saying, yeah, we found that too. So not only did they find it, but if you looked at the table, there was something called a dose gradient, which means the longer you were on the pill, the higher the risk. And that's considered significant because it implies that there's probably a physiologic basis for that. It's just not random. You know, it's like smoking a pack a day versus smoking 2 packs a day. So that was very intriguing. And so there's something called rapid responses for the British Medical Journal. And what that is you can write a letter to the editor and send it in online. And what this person found out was that he said, if odor plays a role in human mate choice, our results suggest the contraceptive pill could disrupt this assorted mate preferences, and I'll explain what that means. What he basically did was he said, look, you know, he was a researcher. At that time he was in Liverpool, now he's in the University of Newcastle. But he published a paper 2 years earlier in August that found that women taking the pill preferred mates that were similar instead of dissimilar, that were similar to them in major histocompatibility genes. And why is that important? Or what would that have to do with anything? The major histocompatibility genes are part of our immunologic system. So the more different MHC genes the offspring has, or a person has, the more likely they are to be able to fight off different germs and different parasites. And so you have to remember that before the advent of antibiotics being developed in the 1940s, the average life expectancy was probably about 47. And the child death rate, even in the first year, was very high. So if there was something intrinsically about a woman that made her want to mate and pick as a mate someone who had these very different genes, MHC genes, than she did, her offspring would have a survival advantage. I had to condense this down into 40 minutes, so all that stuff is in my paper, all the data that substantiates that. So this is what he said in his letter. Hannaford also find a higher rate of violent death among ever users. And that rate of violent death increases with longer duration of oral contraception. evolutionary insights into human partner choice provides a clue. Oral contraception alters women's baseline preferences for men such that pill users prefer men who are relatively similar to themselves. And one consequence of being partnered with similar men is lower sexual responsivity. They reject sexual advances more frequently and have more extra pair partners. So that's when you mate outside of your, relationship with your mate. So it's not unreasonable to suspect that such effects could also influence the rates of intimate partner violence. This is the most common cause of non-fatal injury among women and accounts for more than a third of the women murdered in the U.S. So he thought that Hannaford's paper substantiated that this was an important effect. Because you have to remember, to get the demographics to change enough to pick it up in causes of death, it has to be a pretty strong effect. So we're dealing with that right now. And there's always somebody in the news. I mean, for a while it was Marines killing their Marine girlfriends when they would become pregnant. And, Marines are taught how to kill. And a lot of female Marines were dying. And before that, there would always be some sports figure in the paper where their pregnant girlfriend would get shot while they were pregnant. So that was in 2010. In 2014, there was the Charlton study. And just like they followed all the women in the UK, they follow this group of nurses in the US. It's a data set. And they followed them at this point for 36 years. And what they found was violent or accidental deaths were more common among ever users. So the hazard ratio of 1.2 means there's a 20% increased risk of violent death in those women. So, but what did they conclude? I mean, clearly it's bad if you say something bad against hormonal contraception. Because clearly people who don't use it and procreate, and there will be more people, which is clearly bad for Gaia, Mother Earth, our new religion. So it was bad, and this was an American. So what do we have to say? Instead of saying, yeah, we found that in a study before, and yeah, we had a dose effect. What they said, however, it's unlikely this is a causal association, given the lack of a biologic mechanism. So I kind of always had that in the back of my head for years and years, and I was always thinking, well, it can't be all intimate partner violence. There's got to be something else to it. And sure enough, in 2018, just 3 years ago, this paper by Skovland in Denmark came out in the American Journal of Psychiatry. And she found an association with hormonal contraception and suicide attempts and suicides. And what she found was overall, there was a 97% increase in suicide attempts and a 200% increase in actual people being successful with their attempt and managing to commit suicide. And she even broke it down for the type of hormonal contraception that was used. So 91% of the women had taken oral contraceptives, which are largely the estrogen-progestin combination drugs. But 112% 29% increase in people who use progestin-only contraception. And then the vaginal ring, the NuVa ring, was even higher with 158% increased risk. And the patch was the worst, 228% increased risk in suicides and attempts. So if you look at that from a medical point of view, and you know what's in those different formulations of hormonal contraception, you see that the higher the estrogen level in the formulation, the higher the risk. And I'll get to why that would be. And the other thing that was kind of always got me was that she found out that the effect of increased suicide attempts and suicides, it peaked after 2 months of use. Now, isn't that kind of quick? Because if you think about it, well, why would that be? You know, maybe it's a change in lifestyle and it's getting to people, or maybe it's, you know, doing something to your body, but certainly it's going to take longer than 2 months. But actually it doesn't, because in 2016, there was a study done by Lanfranchi who noticed that there was a change on the MRIs of the brains in women who used oral contraceptives. So she would take a picture, an MRI of a woman's head, so all the sizes of the different brain structures, and then have them start on the oral contraceptives or whatever drug they were using, and then repeat the MRI in 3 months. And in 3 months' time, the left amygdala was smaller. And small left amygdalas are associated with depression and suicide. So those two studies back each other up. The vaginal ring and the patch deliver their estrogen directly into the systemic circulation. So if I take a pill in my mouth, it gets absorbed by my gut, and the veins in my gut go into the mesenteric veins, which eventually go into the portal vein, which goes into the liver, and the liver metabolizes it somewhat and reduces the effect of the estrogen in it because it's metabolizing estrogen. But if I put it on my skin, it'll go directly into my arterial or systemic circulation instead of the hepatic circulation. It won't go through the liver first, and it will have more of an effect. So one of the things that was done was all these things were kind of building up. So last October, there was a systematic review of all the studies of neuroimaging that were done on people taking hormonal contraception. There were 33 articles in the review. 10 found were about brain structure, and 23 were functional effects. So they found that these structural and functional changes were in the affective, you know, our emotional and how we react, that kind of thing, and our cognitive processing. And they involve the amygdala, the hippocampus, the prefrontal cortex, where we think, reason, and the cingulate gyrus. So the limbic system is a very powerful system because that's what makes us express emotion in our behaviors. I mean, think of all the stuff that was done for love and emotion. And no matter how many talks you give, and no matter how intellectually you know certain things are true, unless you connect emotionally to that subject, you're not really going to do anything about it. It's really not going to affect you. It's sort of like saying all your prayers by rote and not feeling the presence of Jesus at times, or God at times in your life, and making that emotional connection like St. Teresa did. So the amygdala is involved with emotion and behavior. We have a part of our brain, the hypothalamus, very important because it regulates our sleep cycles, our temperature, menstrual cycles, our libido, how much we want to have sex, and regulates mood. And the hypothalamus is such a key organ because it connects the endocrine and the nervous system. So the nerves might get stimulated, but what are the results? So what organs, endocrine organs, do they affect? And those endocrine organs secrete different types of hormones. So there are lots of estrogen receptors in the brain, and they're really all over our body. They're in our liver, our cardiovascular system, our bones, everywhere you can think of, they're there. And a lot of people don't really think about that so much. So when you're putting hormonal contraception into your body, you're not just affecting the ovary and whether or not it releases an egg or does other things. And it is an abortifacient, but it affects the blastocyst and embryos. But you're not thinking that way. But it is affecting our whole body. So now what I'm going to do is just go over a few of the findings that I found interesting out of that big systematic review. Psychologists teach women how to be afraid by showing them pictures, like we're afraid of horror movies, things like that, and what our reactions are. And oral contraceptives enhanced fear learning, so you're afraid of a lot of stuff. And that would increase your anxiety levels. So that's why there's so many different effects on the behavior and the emotional state of women on hormonal contraceptions. Now this is what I thought was really interesting. Hormonal contraception interferes with oxytocin response. So oxytocin is released in different situations. Like if you're getting a good feeling from a mate, your oxytocin is up, you're bonding with somebody. It's a good feeling. It bonds you to that person. Sex does that. It bonds you all through that hormone oxytocin. But women who were taking hormonal contraception lost that normal bonding response. Nothing happened. Their functional MRI showed that nothing has happened. And the other thing that oxytocin does is it makes your mate look a lot better. So that adage, beauty's in the eye of the beholder. That's why. It's the oxytocin. It makes you think that your mate is the best looking thing that's around. And so you're attracted. So that's why those women were rejecting sex more frequently. The other thing is that if the hormonal contraception was started in adolescence, those adolescents, even when they stopped hormonal contraception, had a long-term increase in risk of a major depressive disorder. The kind that has you sitting catatonic and staying in bed like 20 hours a day and getting hospitalized for depression. So even those kids, think about the kids that are started on hormonal contraception because they have acne. So I had I was a breast surgeon, and I have these teenagers coming in with lumps, and I do a biopsy, and they had very, very proliferative breast disease from the hormonal contraception they got put on because they had painful periods. So it's crazy time out there. There are other things you can give girls if they have painful periods or acne that don't do those things to them. So they also found that depressed individuals had smaller left amygdala than never depressed people. And that was happening in a normal, when they compared normal cycling women to women that were taking hormonal contraception, their left amygdala was smaller. Adolescents with bipolar disorder had smaller amygdala and had an increased response to emotional stimuli. So you have a problem with teenage. Remember I gave you that 10% statistics? 10% death rate in women or teenagers up to 19 years old is suicide. That's a big problem. 1 out of 10 people don't get to be 20 because they kill themselves. And then you have people that are pushing these drugs that will do that for them, give them depression, make them suicidal. Okay. Then there was another paper that came out after that paper came out in 2020, or 20, whatever it was. It was published as an abstract in December of 2019. And there were radiologists at Albert Einstein Medical Center that took 50 women, 20%, 21 of them, half of them were taking the pill, and 29 were controls. And they found a statistically significant decrease in the volume of the hypothalamus in these women. And that was correlated, because they also gave them a psychological survey to fill out, correlated with issues of depression and with anger. So hormonal contraception changes the structure and function of the brain. 57% of women who are started on hormonal contraception will go to their family doctor and say, it's making me feel funny. And what the American Academy of Family Practitioners says you should tell these women is keep taking it, and it'll feel better, And they just get used to feeling bad. So instead of looking at the literature that they're not exposed to, they don't realize that they could be really damaging these women. Intimate partner violence has gotten so out of control that the American College of OBGYN says that women who come to your office for a pap and a pelvic need to be screened for that. You have to ask them, what is your living arrangement? Do you have a mate? Do you have a partner? Do you feel safe? That's how bad it is. And now you got to think about how many women are taking these drugs. So the CDC says about 82% of women in this country have taken hormonal contraception at some point or another in their life. That's huge. At this time right now, 12 million women are taking some form of hormonal contraception. So that's one effect, the effect on the structure and function of the brain. Now, there's something called borderline personality disorder. And it's a very common psychiatric problem. 20% of all outpatient office visits or, outpatient treatment, 20% have that diagnosis of borderline personality disorder. And I think it's about 10% of the inpatients. So it's common. So in the United States today, there are 4 million women with this diagnosis. And it has characteristics of unstable, intense relationships. Like there's very strong emotions, impulsive and risky behaviors. I like to drive my car fast. I like to check out all the new drugs. I like to have unsafe sex. They also have increased suicides and suicidal threats, that self-injury thing that goes on. I mean, I remember being in the emergency room a lot, and it's not uncommon to see young women come in and they'll have like these like very straight scars on their, because they're injuring themselves. They'll take a razor blade and they'll cut themselves. They call it cutting. They lose their temper, have physical fights. And what's interesting is that their symptomatology varies with their menstrual cycle. They're not on hormonal contraception, they're having normal menstrual cycles. And their symptoms will be the worst when their estrogen levels are the highest. So, I mean, if you think about it, when they were talking about the Gabby situation and her relationship, it was hot and cold. Her friends said, they were either really in love or they were fighting. And I think she very well could have had this type of disorder that led to these types of conflicts. Okay. Now, this is a new topic, kind of. I'm gonna get into what is it physically that's making all this crazy stuff happen. So, S.C. Roberts said it was the odor, right? He said odor made a woman and a man sense whether they were MHC, similar or dissimilar. Okay. So how do we as humans process these different things? Well, in most mammals, there are two circuits that process smells. One of them is an accessory system, and the other is something called the VNO, the vomeronasal organ, the VNO. Now, if you have a fetus and you dissect it, you're going to find the VNO really easy. But in adults, it's much harder to find. Not only that, we have fewer genes that are related to the VNO now, or we just have fewer genes related to that than other mammals. So most or many scientists believe that there's no VNO in humans. So I'm going to give you my take on the VNO, which I think does exist. So there is this system that's known to detect non-volatile pheromonal odorants. So pheromones, usually you think of those Japanese beetle traps, where the traps have like really good smells for the bugs that are related to mating, and they all go in there and get the poison. So those pheromonal odorants include, at their effect, sexual attraction and mating, and release of the luteinizing hormone from the pituitary gland. But that there's also a second circuit, an olfactory one, Now, people do know that there are certain scents and essential oils, like there are things that will make you more alert, like peppermint. There are things that will be calming, like lavender. And there's a big science about that, companies that test different odorants. But there's this thing about, we don't really think that there's a functional VNO in humans. So I'm just really telling you this in a little detail because you'll get a lot of people say, oh, that doesn't exist. So actually, in the 90s, there was a lot of research done by Monty Block, who's a psychiatrist, and colleagues. And he wrote a lot of good papers on the VNO. And what that is, it's like a blind duct. It's a cul-de-sac. Instead of being an organ that, you know, there's a passage like a duct where secretions will go through. This is a blind pouch. And it's really small and hard to see. So if you look at that little arrow there, at the tip of it, you see a little dent. That's the opening. So to me, it's no wonder people aren't finding this in adults or having a hard time or saying it's only present in a certain percentage of people. It's there, it's just hard to find. You gotta look for it and you have to know what you're looking for. So he did these, and if you look at the bottom picture in the middle, that's the cul-de-sac. That's the organ. And it has very specialized cells in it that are different than the respiratory epithelium that maybe makes mucus for you and lines your nose, or the parts of your nose that do detect odors. So he did a series of very elegant studies. He used a 0.millimeter electrode. So you know how small a millimeter is. There's like 24 millimeters in, never mind. There's 2.5 centimeters in an inch. And 240 millimeters, and this is 0.1 millimeter. And he surrounded that by a 0.5 millimeter Teflon tube. I mean, think of the rulers you've seen in your life. They always have the inches on one side and the metric system on the other. The littlest lines are the millimeters. And he surrounded that by a 2 millimeter Teflon tube. So the 1 millimeter electrode would stimulate the cell, and the 0.5 millimeter tube would give in that area the chemical. And then the larger tube around it would suck the chemical out, so he couldn't be tricked by having some still in the nose that he didn't know about. It was like a continuous vacuum system. So he got it down so only a 1 millimeter, very small area was stimulated. So he defined 3 kinds of lining to the nose. That's called the epithelia. There was a certain type in the VNO. There was some in the olfactory that were different than the ones in the respiratory. He tested 2 chemicals that had odors. And put it under your nose, you can smell it like you can smell an orange. But then he had 6 chemicals that you couldn't smell. 3 of them affected males and 3 of them affected females, because these pheromones have to just be effective towards our binary sex system that we have. He didn't know about all the others. He also measured skin temperatures and what was happening in their brain. And so you can see that with the chemical pH-15, and he put that electrode on the on that epithelium, and that chemical stimulated it to produce that tracing. But it didn't stimulate the OE, the olfactory, or the respiratory, RE, respiratory epithelium. They were unaffected. And in the second line, he had something you could smell, the one carb. And that only affected the olfactory and not the VNO or respiratory. So he could demonstrate that these two chemicals were doing exactly different things. And he also did a thing where how high was the concentration. So if you had a really concentrated chemical, then the potentials would be much higher. And if you put it a certain distance from the epithelia you were trying to stimulate, the potentials got lower the farther away you got. So it's really much more detailed from that, but that's basically the gist of it. But what clinched it for me is one of the chemicals that he was testing as a vomeropherine, or pheromone, was one in women that stimulated women. It didn't stimulate men, and it didn't stimulate the odor, and it didn't stimulate the respiratory epithelium. And it was pH94B. And in that 1994 paper, he said, look, we're just giving you the numbers of these chemicals. We're not telling you the actual chemical composition, because we might do something with it later. But this was how we labeled it. And that has gone through a phase 2 trial as a nasal spray. So if he already did those studies on it that showed that it didn't stimulate the respiratory or the olfactory, and it only stimulated women on the VNO epithelia, and now he's got a drug to do that, I think that's pretty clear. That there must be something there in women. You know, that this VNO organ has an effect. So, those chemicals had no discernible odors, had different effects on the brain, skin temperature. He also showed that that there are male VNOs that affects serum testosterone levels. And he also looked at what functional brain imaging studies with MRIs when he stimulated the VNO with these pherines. And they activated the hypothalamus, amygdala, and cingulate gyrus, which is all part of that limbic system that I talked about before. And then I always like to see something that's clinically relevant, because I was a clinician. I treated patients, and I wasn't treating papers and, rats. There were these Czech surgeons, and they did orthognathic surgery. So if you have a jaw deformity, you have to move the facial bones around and your jaw around to get a good normal bite. And so the surgery to correct jaw deformities often would destroy the VNO because they know where it is. And what they noticed in their patients when they did this kind of surgery that affected the VNO, that destroyed it, that their patients had frequent mate changes and became more promiscuous. Now, people would say, well, maybe they did that because they were better looking now. They didn't have a deformed jaw, or lantern jaw, or whatever, and they just looked better and had more girlfriends. But that would be true in any cosmetic surgery, plastic surgery patients, and that wasn't the case. Plastic surgery patients don't suddenly become promiscuous. So they postulated that the VNO had an inhibitory role regarding what would be suitable mates, because apparently they were picking ones that were really not suitable. to them. So that's the BNO. There's a lot more detail in my paper, if you could stand it. So now this is the last topic. So, if you have a girlfriend and a boyfriend, and the girl says, I'm taking the pill, and the girl gets pregnant, she's trying to trap him. She probably didn't take the pill because she wanted to get pregnant and trap him into marriage or something. Because everybody has this belief that it's 100% effective, but it's not. And if you go to the CDC and they tell you the effectiveness and the failure rates for the different forms of hormonal contraception and any kind of contraception, there's a 9% failure rate for the pill. That's, the oral, the estrogen progestin combination drugs. So if right now we have 6.4 million women using the pill, there's going to be 576,000 unplanned pregnancies a year. What's going to happen to those pregnancies? So who would you ask? You'd ask Guttmacher Institute, because they keep statistics on how many women come in seeking an abortion who say, I was taking the pill this month that I got pregnant. And they know the percentage of women that will go through with an abortion when they show up. So there are about 241,000 abortions every year because hormonal contraception and the pill, just the pill, not the other forms of hormonal contraception, which have their own failure rates. Like the progestin-only pill, the mini pill. Isn't that good? It's a mini pill, and little, and it's not harmful, and it's wonderful, and it's progestin-only. But you have to take it exactly the same hour every day. Like I take my pill at 10 a.m. or I take my pill at 8 a.m. And you have to take it at 8 a.m. for those 3 weeks. Otherwise, it doesn't work. You get a lot of failure rates. 50% of the time when you're taking the mini pill, you ovulate in those cycles. So that's a lot of unplanned pregnancies. So we could end a lot of abortions if we let women know. They did a survey of women and they said, how effective do you think the pill is? 45% of them overestimated how good it is. So the teenagers are not at fault when they get the pill and they get pregnant. They say, oh, they're missing them. No, they're not. They're just extremely fertile. They can smell semen and get pregnant. So, what about children? Did anybody ever hear that there was an association between hormonal contraception and autism spectrum disorder? But there are studies that show that. So when you think of the millions of women on the pill, and then how many of them get pregnant, and how many of them, a lot of them, keep the baby, they don't have abortion, their kids are more likely to have autism. And so doctors love to do things to rats and different other, animals. And so what they did was they had, they gave levonorgestrel to pregnant rats. And what that did was it suppressed their estrogen beta receptors in their amygdala. And their little baby rats and their litters had autism-like behavior. So there are behaviors you can pick up in rats that happen from hormonal contraception. So one of the popular things is, RU486, mifepristone, chemical abortions. There's a lot of chemical abortions now. And they chemically aborted rats. And so there's certain behaviors that happen. So the rats, after they were aborted with mifepristone, would sit in the corner, not groom themselves. They had really strong negative behavioral, they didn't socialize. They were clearly not the happy rats they were before they got the mifepristone. So now levonorgestrel is a progestin, a synthetic progesterone. So in this country, for estrogen, we use ethinyl estradiol as our synthetic estrogen. So our body really can't metabolize it. And the only way we can get rid of it is to pee it out, which then goes into our sewer system and the water treatment plants. The only problem is they don't run them through charcoal or something else to get rid of the estrogen, and then they put the effluent in the rivers. And then downstream from the rivers, from the sewage treatment plant, the fish will have ambiguous genitalia. The males, salmons, and different fish that they like to fish don't procreate correctly because they do have ambiguous genitalia, just from that amount of estrogen. So progestin is the hormone that so you have your ovary. I know you guys know this stuff because you've done probably NFP or something or learned about it. So after the egg is released, there's like a divot. And that divot becomes the corpus luteum. And that corpus luteum is what makes progesterone. You have to have a certain level of progesterone for you to get a good thick endometrium so that you can have a good viable pregnancy. So some women don't make a good corpus luteum, and you want to help them if they look like they're getting into trouble, with spotting early on in pregnancy, or have even lost them. So progestin is used to prevent a threatened abortion. A threatened abortion is when a woman looks like she's going to have a miscarriage. Well, sometimes when you're taking that drug, like you're taking a progestin-only pill and you get pregnant, or the women taking the estrogen progestin drugs and they get pregnant, it's going to be around the time of conception. So what's going to happen to those kids that are now developing in a very abnormal environment of very, very, very high levels, much higher than they normally are? And what's the biggest part of the developing embryo? It's their brain, all the nervous system, and with all those estrogen receptors. I'm depressing people, I can tell. So, if they used levonorgestrel, the Chinese do stuff to women, and if they fed the progestin to fish, so the progestin was in the fish, and those fish also got small amygdalae, and they fed those fish to pregnant women, the kids would come out autistic. So I guess there was a problem in China that they were trying to figure out. So we're affecting the children that you want to have with these drugs. So what's another problem with hormonal contraception failure other than what you're doing to the poor kids? Well, some of the women are going to end up having an induced abortion. And so there's been a lot of studies done by that, about those effects. And in 2011, Priscilla Coleman did a meta-analysis published in the British Journal, and this is what she found. There's some concept and number you can derive if you're a statistician, epidemiologist, called attributable risk, population attributable risk. So for breast cancer, if you're taking the pill, about 15% of premenopausal breast cancer is because you're taking an estrogen-progestin combination drug. It's a lot of women. So what she found for a population attributable risk was an increase of 34% in suicides, 20% in suicidal behaviors, 8% in depression. Then they also had a fondness for alcohol and marijuana, drugged. And we know that substance abuse can lead to accidental deaths, either because you're driving impaired, falling off a cliff, thinking it's good to do certain things that it's probably not good to do, and they all have accidental deaths. Now, can we do anything about it? And I think this is an important thing. We can do something about it. In 1999, there was a woman, Gisler, who took the vital statistics records in Finland. Finland is not a big Scandinavian country, so, and all, you know, they have socialized medicine, everything's on the computer, it's not that hard to do. So within a year of having an induced abortion, there was an increase of 340% of homicides, 270% suicides, and over 100% in accidents. So these women were getting killed, killing themselves, and having accidents. And she thought that that was too much. So she said, you know, a lot of women are killing themselves, and maybe these accidents are really suicide. So why don't we do this? We'll make them, well, not make them, but we'll have them come about 3 weeks after their abortion. We'll talk to them. We'll see how they're doing. And we'll give them counseling if we see after depression and suicide screening that they are suicidal. And what she found was when she did that, or when the country did that, there was about a third reduction in all those deaths. So these are all bad things, but there are things that we can do about them simply because we know that they happen. So a leading cause in the United States of maternal mortality is homicide, and 30% of those are from an intimate partner. So what you want to do is when you have a pregnant woman, you ask her, you know, what her living situation is and how does the father feel about the child and things like that. And maybe you can extract her from a bad situation and help her or counsel her. So this was a study I told you about before by Camilleri at the University of Steubenville. She was the one that gave those poor rats that she liked. She said she felt bad doing this, giving them the mifepristone to induce abortions in them, and they had reduced grooming, exploratory. They just sat around. They were immobile. So, what are some of the behavioral changes? Women who are taking oral contraceptions report an increase in feelings of jealousy. And jealousy is a big driver for what they call mate retention behaviors. So there's a mate retention inventory of questions that you can ask people. And